So now it's time to our last speaker, Dr. Khalil Ibrahim. He's going to talk about TAVR in bicuspid aortic stenosis with large annulus. Dr. Khalil, we are waiting for you and sorry for keeping you waiting all of this time. Dr. Khalil. So, do you hear us? Please unmute yourself.
Can you hear me?
Yes.
All right, let me just share my screen. All right. Okay. Thank you so much for inviting me. It's a pleasure to be here. I'm an interventional structuralist at the University of Illinois at Chicago. And I wanted to present a case I had this past spring, which had a couple interesting features. Okay. So just jumping straight into the case background, this was a 61-year-old gentleman, past history of hypertension, diabetes, peripheral vascular disease, paroxysmal atrial fibrillation on apixaban, prior coronary disease, and interestingly, five-vessel CABG in 2018 with the above anatomy, and he was known to have aortic stenosis at the time. Unclear to me what the severity of it was, but they did not do AVR 3 years ago. And he was doing fairly well until about 2 months prior to his presentation to our hospital, and he started developing worsening exertional chest pain and shortness of breath. And he was previously very active, working as a forklift operator on his feet all day. So he presented to an outside hospital with those symptoms, and he underwent cardiac catheterization, and he was noted to have very severe both native and bypass disease. His vein graft to the obtuse marginal and vein graft to the diagonals were occluded, as well as his distal LAD, which was distal to the lima anastomosis. It was noted to be very diseased vessel. They did do balloon angioplasty, no stent placement of the LAD at that time, and then his echocardiogram noted severe aortic stenosis, but he was stable at that time, and they discharged him with plans for an outpatient workup, and it didn't seem like he got very far with that. As he presented again to the same hospital about 2 months later with significant kind of unstable symptoms, dyspnea at rest, chest pressure, did have an NSTEMI with a troponin I around 15. And he was evaluated by cardiac surgery at this hospital and was deemed too high risk for surgery. And their thought was that he's a reduced sternotomy and has severe coronary artery disease that really isn't amenable to revascularization. I'll show you the films here in a little bit. His obesity, reduced sternotomy, as I mentioned. So they asked him to be transferred to our hospital for a second surgical opinion. And our surgeons were a little hesitant and wanted to see if he was a candidate for TAVR as well. So here's some still frames of the calf, and what I'll just point out is that he had very severe native left-sided disease. He didn't have, his graft to his OM was occluded, graft to the diagonals were occluded. His right bypass was open and looked good, but here's his lima to the LAD, and you can just see the LAD really is non-existent distal to anastomosis. Here's his echo. And what you can notice, he has a slightly reduced ejection fraction. We called it about 45%, but you can already see that he has a very calcified aortic valve. And here in the short axis, I can't get that to play. There's a hint of it being bicuspid, but you'll see clearly in the CT that it is. And then he had about a mean gradient of 40. Go to the next slide. Sorry, computer's being a little slow. Let's see, here we go. Oops. Sorry, my PowerPoint just shut down. Let me bring it back up. see. Okay. So here's his TAVR CT. So with these CTs, I'll go through the full report, but we start by looking at the annulus to see what the area is, which judges kind of what valve size we choose, as well as looking at any calcium, which he does have some here, calcium here in the annulus, as well as the LVOT. Here in the sinus, you can see this is clearly a bicuspid, probably type 0 bicuspid aortic valve. A little bit of calcium here in the STJs. Coronary heights in this case were good. The left was 18, the right was about 18 as well. And then here you can see that it's a heavily calcified valve, particularly on the this left-sided leaflet. And then looking at his peripheral vasculature, we see that it does look amenable to TAVR. Vessel diameter is good. He does have this infrarenal abdominal aortic aneurysm that is to be noted and be careful about, but this access did not look prohibitive to TAVR. But one of my initial concerns is if you look here, this is the kind of IFUs for both the two commercially available valves here in the United States, the Edwards balloon expandable Sapien has instructions for use up to 683, and for the Evolute self-expanding, the largest valve has they go by perimeter of 94, and if you look at our patient, he had an area of 727 and a perimeter of 96, so starting to get outside the range recommended by the companies. And so, well, what is the data for TAVR in large annuli? There aren't a lot of good data in terms of randomized controlled trials or anything of that nature, but there's some registry data. This was recently published last year, multi-center registry data from the US and Europe that looked at large and extra large annulus and TAVR and what were the outcomes. And combining that, they had two groups within this study. They had large annulus, which actually were within the IFU ranges, and then the extra large annulus, which were outside. And both groups actually did have pretty good outcomes. If you look at with the Sapien, 95.8% device success, low rate of significant paravalvular leak, low rate for need for a second valve embolization. The Evolute had a little bit worse outcomes, but still fairly acceptable. And then when you look at the extra large annulus, there was increased risk of paravalvular leak and device embolization, but mortality was fairly similar. And then specifically looking at Edwards, there's this study led by Gilbert Tang that looked at multi-center study looking at multiple Sapien, particularly in extremely large annuli. I think theirs range from 683 to 852 in terms of area. And generally it looked like they had pretty good outcomes. They're looking at here in hospital and 30-day outcomes, and 30-day mortality was 2.7%. Risk of moderate paravalvular leak was only 6.9%. There was no severe paravalvular leak, and central AI was also fairly rare. It's a little bit encouraging. And one other thing that they noted that predicted more significant paravalvular leak was looking at this annular to LVOT area. And they noted that in patients who had larger LVOT areas than their annular areas tended to have more significant PVL. And the theory was that the LVOT contributes into sealing here at the bottom of the skirt in TAVR valves. And if you're removing part of that sealing zone, as in the LVOT is large and not making contact with the valve, then you're just more prone to having leak. And so if you look at our patient, in fact, his area of the LVOT was larger than the area of the annulus. So kind of a sign that this patient may be at increased risk for paravalvular leak in TAVR, combined with him being bicuspid. So we had a heart team discussion. This is kind of a summary slide of all his features. Young age of 61, diabetic, peripheral vascular disease, good kidneys, prior sternotomy, class 3 symptoms, mild AI, in addition to severe AS, and his STS score came out to about 7%. So in discussion with the team, I recommended surgery. I thought he's a young individual, 61. He's likely going to need a second, or even if he lives longer, a third valve over his lifetime. Combined with being bicuspid and having an extra large annulus, he was at increased risk of complications in TAVR, and I considered him a high-risk TAVR candidate. But our surgeons, as well as the outside hospital surgeons, turned him down, and so we had the situation where the interventionalist is recommending surgery and the surgeons were recommending TAVR. And I talked with the patient extensively about the risks of this and actually offered him a third opinion, whether we could transfer him to one of our other hospitals in the area and have another surgeon weigh in. But at this point, he was pretty fed up and didn't have a great experience of his prior surgery and really was in favor of TAVR and understood all the risks involved with that. So we started planning for this. Our plan, we do 95% of our cases moderate conscious sedation with anesthesia support. We're planning right transfemoral access. I pre-dilate all my bicuspids in TAVR to kind of break open the commissures and get a more predictable valve deployment. I chose a SAPIEN for a number of reasons. One, with his young age and coronary disease, potential needed for coronary access, but also, he's likely going to need another valve down the line, and the risk of coronary obstruction is a lot lower if you start out with a SAPIEN balloon expandable valve due to the shorter frame and leaflets. And seemingly with the data I presented previously, that SAPIEN may have better outcomes, and there's more experience with it for very large annuli. Given the bicuspid nature, I was going to aim for a higher implant for better seal, kind of a 90-10 deployment. And given the severe coronary disease, I was worried about numerous and long pacing runs, him becoming ischemic and hypotensive. So was hoping to minimize his runs as much as possible. And then, again, with the risk of PVL and device embolization, we wanted to make sure that we had a second valve available in case one of those things happened. And then, kind of warned everyone that, there is a chance that if he doesn't do well, we may have to do something surgically on the table. So in terms of the +3, so I mentioned SAPIEN, and we needed to overexpand this. There was a trial, or a study, not a trial, but a study where they looked at serial patients where they overexpanded SAPIEN valves, and then they did CT scans after the fact. And basically what they noted was that for every cc that you add extra to nominal, you gained about 0.5 millimeter of diameter for the valve. And so we chose 3. We debated between 3 and 4, but we ended up choosing 3 cc's to be a little bit conservative with this bicuspid valve. But the bicuspid part may offer a better seal. So here is our, hopefully this plays. Let's see. Maybe taxing my computer here a little bit. Let's see. Okay. So here's our aerogram. So, what I'll point out is obviously heavily calcified. You can see his leaflets even without contrast. And then he already starts with a fair bit of aortic regurgitation. Echo had said mild, but this is kind of bordering on mild to moderate in my opinion. So here's his invasive hemodynamics. We got about a mean gradient of 40 before any intervention. Here is our balloon valvuloplasty with a 20 millimeter balloon. Good expansion. And so following this, the patient did become hypotensive, could be for a combination of factors. I think he probably developed a little bit more aortic regurgitation following this valvuloplasty based on the hemodynamic tracings, but also, with the rapid pacing run, may have become a little ischemic. So we moved fast at this point, quickly exchanged the balloon for the valve system. And here's our valve deployment, plus 3 cc's under rapid ventricular pacing. And what I'll say, after this, he did not regain a pulse, and we had to do immediate CPR, administer epinephrine. After about 1 round of CPR and 1 milligram of epinephrine, he did regain his pulse. He was emergently intubated, and then when things were a little bit stable, we performed a repeat aortogram. And what you can see here is significant paravalvular leak. So at this time, we quickly reintroduce a balloon. We add extra contrast. So we added an extra 2 cc's to our already plus 3 cc's. So we end up with plus 5 cc's. And as you can see in this picture, we actually did not need to rapidly pace because the patient was pulseless at this time. So we quickly inflate, and then we do about 10 seconds of CPR, and then all of a sudden he's got return of circulation and his systolic blood pressure is in the 200s. And this actually persists, and we actually end up having to give nitroglycerin to bring down his blood pressure. This is his final angiogram of the aorta, and really only has about trace paravalvular leak at this time. And then this is his Hemos afterwards. Again, very tachycardic. We think the epinephrine is still circulating at this time, but we got a mean gradient of 4, and at this point, we're fairly happy and decided to call it a day. So his post-op course, overnight he remained intubated and actually required nitroglycerin drip all night to manage his hypertension. He was extubated the next day. His echo the next day showed his EF was a little bit lower than previous. He had a mean gradient of 7 with trivial paravalvular leak. Discharged on post-op day number 3. Saw him in clinic recently. He's back to work, asymptomatic. Actually was fairly emotional in the clinic, just very grateful about how much better he felt. And his echo a month out showed his EF had improved to 50%, mean gradient of 7, and no paravalvular leak at this time. So I guess my summary slide didn't make it up here, but my kind of thoughts at the end of this, I think this patient still, he did well and we got lucky, I think, but, I think surgery would have been the best option in terms of dealing with this bicuspid valve and paravalvular leak. I think, TAVR and large annuli is certainly feasible and supported by the data and by my experience, but really should be reserved to high-risk patients. I don't think this is a procedure that we'd be doing in low surgical risk patients for sure. And I'll conclude there. If anyone has any questions. Let's get out of this.
So thank you so much. We are fascinated about this high-risk case and very good final result. So now we have many of our panelists. Ahmed, would you like to comment on this case?
I'd like to congratulate you for such a challenging case, and I did appreciate the pre-TAVI strategy planning and preparation, and this is the core for a successful TAVI. Studying all the options and getting prepared to the complications that might happen. I have a couple of questions because you were dealing with a very critical patient, and you were even preparing for an emergency sternotomy because of the critical situation for a surgical shifting to a surgical aortic valve replacement in such a scenario. When we have such a critical patient, sometimes we do prepare the patient for a heart-lung machine or ECMO, and we even cannulate the femoral artery and vein just if the patient went into severe hemodynamic compromise. So did you do you follow some similar strategies or not? The other point is sometimes when you are expecting a significant paravalvular leak, you get prepared with a closure device, I mean a paravalvular leak device that you might insert immediately if you couldn't correct the significant paravalvular leak with the post-valve dilatation. So these are my two questions. And again, congratulations for the case.
Thank you. Yeah. So we thought various. We do have bypass in the room available, and we had all the cannulas. We were prepared. Where I trained, we would have considered starting this case with cannulation and being prepared. The problem of our hospital is we actually don't have ECMO. Obviously we do bypass surgery, but we don't have ECMO for the ICUs. And no staff to maintain afterwards. And so our surgeon was they had done that before I came to this hospital once, and it was very problematic when they did it because they wanted to keep the patient on ECMO, but then they had nowhere to go. So it was kind of a long time in the room. And so, but it's a very valid point, and definitely we talked about it, thought about it, and we have the machine in the room. It is a good point about getting additional access. We did not. We did stay all transfemoral, so we had our large access on the right, and we had a 6-French sheath on the left. Obviously, we could have quickly escalated that for arterial cannulation, and then our pacemaker also went through a femoral venous sheath on the left. So we could have fairly quickly gone on to ECMO, and we were actually, when the patient was arresting, we had perfusion come in the room. We were kind of getting the circuit ready, but thankfully he didn't require it. And then in terms of plugs for paravalvular leak, yes, we did have a variety of Abbott implants closure devices. Sorry, I didn't mention that. We do have that in the facility, and in the back of our minds, if we had stable paravalvular leak was something. The question is whether to close it there on the table or see how the patient does over the next few days and then maybe bring back if still significant leak. So we talked about it, but thankfully hadn't had to use it.
Thank you so much, Dr. Ibrahim. That was a really challenging case. Here I'm Hani. I have to admit I'm an echo guy, so you should expect having some echo questions from my side. I'm speaking about such cases when you anticipate that you might have a significant degree of paravalvular leak because of this difficult anatomy. Would it be a good idea to have a TOE on board and sedate the patient generally from the beginning, and just to shorten the time of seeking an echo guide to check whether this leak is coming really like paravalvular? I know in some patients like yours, it was quite clear that it's coming paravalvular. But in some cases it is not, and I've been called several times in different hospitals to check from where this leak is coming, and that actually takes time, especially if I'm busy with other things. So I know you have done this case with moderate sedation, but in such high-risk patients in terms of having paravalvular leak as a complication, what do you think about having a TOE on board beforehand? Thanks.
Yeah, no. I totally agree, and that was there were, if I could change two things about the case, one would be I would have had the patient intubated from the start, and I think I've changed my practice a little bit in these very high-risk patients. I think that, it's very, unsettling when the patient's arresting and then trying to get patient intubated at the same time. I regretted the decision to stick with moderate sedation from the get-go. I think this would have clearly been better if we had intubated at the beginning. We do transthoracic after every valve deployment in the room. And again, TOE would have been great because, you know, in the midst of a patient arresting and having CPR, we just didn't have there was not an opportunity at that time to do the transthoracic because, you know, you have to get the sterile sleeve and all that. And so it's kind of very hectic. So 100% agree with you. I would, if I could have done it over again, I would have started with patient intubated with TOE. And then the other thing I would have done is probably gone with a little bit more CCs. So we started with 3. I'd actually talked with our device reps about starting with 5, but was talked down. But I think I would have started with 5. They were worried about the risk of balloon rupture with starting out with a higher CC from the beginning. There's actually been some studies on that. There's a group that did some bench testing, and really it seemed like you were safe up until 7. At 7 cc's, they found that 100% of balloons ruptured at 7, but below that, none of the balloons ruptured. But those are the 2 things, but very, very good points, and 100% agree with you.
Thank you.
So, Dr. Sobhi, your final question or comment?
Try to explain to me again what about the CC, 2 cc, 3 cc, 5 cc. You're using the same balloon as you started, it's 20. And when you do it on the paravalvulic, you said that patient is arrested, intubated, and you go for the balloon and you make it blown up for increasing the CC. It is feasible with the same balloon, or you choose to bigger balloon?
Yeah, so it's yes, it's from the same. It's the company's balloon that they use to deploy the valve. When we say nominal, that means that's the amount of contrast that they put in for every 29 millimeter valve to get nominal expansion. And then every CC you add extra is overexpanding the valve larger than it was than nominal. And so to start the case, we added 3 CCs to the nominal volume. And then, you know, after we got return of circulation and we knew we needed to post-dilate, we had the same balloon. It was actually still in the body, and we added 2 more CCs to our original inflation. And as I mentioned earlier, you gain about 0.5 millimeter of valve diameter for every CC that you add. Now, if the other
okay, go ahead. So it's like the Inui balloon in balloon mitral valvuloplasty. I mean, you know, we're doing balloon valvuloplasty by multi-track and also by Inui balloon. The Inui balloon, each time you can increase the size of the balloon by every cc. So it is the same concept of the same balloon, but with the measuring of the balloon size. So increasing the cc, it is the same like this?
Yeah, exactly like the NOA, where you add volume to increase the diameter of the balloon. It's like a semi-compliant balloon.
So it's not non-compliant. It's a semi-compliant balloon.
Correct.
So semi-compliant, increasing to get it. It is special for the bicuspid.
Yeah, and if you wanted to go larger,
thank you very much.
6 or 7 cc's, it's best to not use the company balloon, but get a non-compliant balloon that's larger to further inflate, because balloon rupture is certainly a risk when you start getting above 6 or 7 cc's.
At the end of this fantastic session, I'd like to thank Julia and all the board of Jack Case Reports because of those fantastic cases they presented. Thank you, Julia. Thank you, Antonio. Thank you, Eugene. Thank you, Khalil. Really a nice cases, and I think we will continue cooperation between Yava CardioGo and the case boxes, as we mentioned before, Julia. I'd like also to thank Professor Muhammad Sobhi for his elegant moderation as usual, Professor Nabil Farag, and also I'd like to thank Professor Ahmed Saib, Professor Hani, Professor Karim, Professor Gamila. Thank you all, and I hope to continue cooperating with Jack Case Report. Thank you, Julia.
Thank you very much. Thank you all. Bye-bye.
Bye-bye.